Hello everyone, my name is Manten and in this presentation I would like to discuss the posterior fossa with you, and hopefully after this presentation assessing the posterior fossa has become a little bit more easy. If we assess the posterior fossa, there are a few important questions. The first one is about the fluid in the posterior fossa. Is it normal? Is it too much or is it too little? Then we have the shape of the fourth ventricle. Is this normal? Then we have the shape of the firmus. Do we have a primary fissure? And is there a normal ratio of tissue above and below the primary fissure present? What are the measurements of the firmus? What's the insertion of the tentorium? Is it normal? And what about the position of the choroid plexus? First, we're going to take a look at planes that are all familiar. If we make this plane, then we can see here this image where we can see the superior part of the firmus. And if we tilt our transducer a little bit, we can make this plane where we can see the inferior part of the firmus. We can also see the fourth ventricle, which is closed and has no connection here with the cisterna magna. And the cisterna magna we find behind the cerebellum. And if we measure the cisterna magna, this should not exceed 10 millimeters. And then, of course, we can also measure the transcerebral diameter, which should be in millimeters and should be the same as the gestational age in weeks. To have a good look at the posterior fossa, it's important to make a sagittal view. So, if we make the sagittal view, we get this image, where we can see the fastigium over here, and there the cerebellar firmus. Another important thing that we can see in the sagittal view is the torcular hierophily. And the torcular is the place where the tentorium is inserted on the inside of the skull. And this is also the point where the sagittal superior sinus, the straight sinus and the transverse sinus are coming together inside the confluence of sinuses. And at the same point, the tentorium is inserted on the inside of the skull. And here in this fetal MRI, we can see that there we have the insertion of the tentorium, and on the outside of the skull we can see the insertion of the neck muscles, which can help us to see if the point of insertion is normal. What should a normal firmus look like? Well, first we have the fastigium, or also known as the fourth ventricle, which we can see over here. And then we should have a primary fissure, which you can see over here. There should be twice as much tissue of the firmus below the primary fissure as above. So this ratio of 1 to 2 should be there and is consistent continuously during during pregnancy. So this proportion stays always the same. If we want to look at abnormalities of the posterior fossa, it's always good to look at the embryology, the development of the cerebellum, which helps us understand what goes wrong when there are abnormalities. So here you can find an embryo of about 10 to 12 weeks. And if we look here at the rhombencephalon, this is the brain vesicle from which the posterior fossa develops, we can see here that the brainstem and medulla have made the pontine flexure. There we have the fourth ventricle, and what we're particularly interested in is the roof of the fourth ventricle. And here we have a schematic view of this part. Here we have an anterior part of the roof, and there we have a crest, and there we have the posterior part of this roof. This is your anterior membranous area, and this is your posterior membranous area. And if we look what happens during development, we can see that from the anterior part of this membranous area, the firmus will develop. You can see it over here. So posterior, firmus, all part of the anterior part of this membranous area. This crest you can see over here and over here. From this will the choroid plexus develop, which you can see over here and there and there. From the posterior part of this membranous area, the Blake's pouch will develop. And this Blake's pouch will intrude below the posterior, the vermis, inside the arachnoid space. It will become a cyst, and then the walls of this cyst will fenestrate, and then we have an open connection between the cerebrospinal fluid inside the brain and outside the brain through this foramen of Magendie. And we see that the choroid plexus is situated a little bit below the vermis on the outside roof of this Blake's pouch. If we make this plane, again, we can see here the Blake's pouch. And I'm sure that everyone has seen the remnants of the Blake's pouch in the cisterna magna, which are these echoid lines over here. They're nothing else than the remnants of this Blake's pouch, which has fenestrated. And again, if we look at this image, we can see it over here too. Then we're going to take a look at variants of this Blake's pouch. And so this is the normal situation, and here we have the megacisterna magna. So if this pouch extends more, and then we have a megacisterna magna, we have a normal firmus with a normal position of the choroid plexus, but much more fluid inside the posterior fossa. If we have a Blake's pouch cyst or a persisting Blake's pouch, what will happen is that the walls of the Blake's pouch will not fenestrate, so there will be no open connection between the inside and the outside, and this cyst can grow, which pushes the cerebellum a little bit more upward. So you have an upward rotation of the firmus, but it is a normal firmus with a normal fastigium and a normal shape of the firmus, and also a normal position of the choroid plexus. If we look at a firmus that is completely developed, we can see that there are all kinds of lobules, which have a name but also a number. And the tissue that has developed, it's a little bit the same as the cerebrum, where if the brain parenchyma is developing itself and is thickening and is proliferating, then you get a lot of tissue. And that's why we have sulcation and gyration, otherwise the brain wouldn't fit inside the skull. And we can see a little bit the same of the firmus, only here it's called foliation, like the leaves of a tree, which you can see over here. And all these parts and lobules of the cerebellar firmus have their own function. For instance, if we look at this part of the firmus, this is necessary for balance, for position, and for tone. This part of the firmus is important for proprioception, coordination of movement. And this part of the firmus is important for planning, cognitive and language functions. So you can understand if something's wrong with the firmus, it's really important which part of the firmus is missing in what the prognosis for the baby or the child will be. If there's a problem in this part of the firmus, then there will be cognitive and language disorders. And if there's a problem over here, something's wrong with motoric function. First, we're going to take a look, and we're going to look at the abnormalities. And the first abnormality that I would like to discuss is the megacisterna magna. And if we look at the megacisterna magna, there's a depth of more than 10 millimeters of the cisterna magna, we can see that in the axial plane, the cerebellar firmus is intact. We have in the sagittal plane a normal position of the firmus, and we have a normal fourth ventricle, like you can see over here, and there's a normal position of the tentorium in most of the cases. And because we have a normal shape of the firmus, usually the prognosis is really good. So how does it look like on ultrasound? Here we have the axial plane, where we can see the cerebellum, but here a cisterna magna, which is more than 10 millimeters. And then if we look at the sagittal views, here we have an ultrasound image, there we have a fetal MRI, and here we have a postnatal MRI. First we see a normal firmus. So we see a normal primary fissure, we see a normal ratio of 1 to 2 tissue above and below the primary fissure, and we can see a normal position of the firmus. Then we look at the tentorium, and we can see that it is inserted in a normal position over there. So what about the abnormalities with an open fourth ventricle? Like we can see over here. Here we have the fourth ventricle, cisterna magna, and there's an open connection between them. What's wrong here? Is this a Blake's pouch cyst, which usually has a good prognosis? Or is this a Dandy-Walker malformation or Vermeer hypoplasia, which have worse prognosis? We go back to the schematic drawings. Again, this is the normal situation. Here we have the Blake's pouch cyst, rotated upwards, but with a normal vermis. And here the cyst-like structure, which is pushing the vermis upwards. And there we have the Dandy-Walker malformation. And with the Dandy-Walker malformation, you can see that you have an abnormal vermis. Also, it is a cyst-like structure and an abnormal position of your choroid plexus. And if we go back to the development of the posterior fossa, you can see that this is a problem of the posterior part and posterior membranous area, and because there's no good fenestration of this Blake's pouch. And here you can see you have a problem of the anterior part of the membranous area, because here you have an abnormal vermis. So, if we have a Blake's pouch cyst or a persistent Blake's pouch, we have an open fourth ventricle with a cleft in the vermis and the axial plane. If we look at the sagittal plane, we have a normal vermis, only we have a superior rotation of the vermis. And we have a normal position of the tentorium. And usually this has a good prognosis because we have a normal shape and size of the vermis. And like I said before, this is a problem of the posterior part, this part of the the posterior part of the membranous area with a normal position of your choroid plexus over here. So what does this look like on ultrasound? Here we have in the axial plane an open fourth ventricle, and then we take a look again at the sagittal planes in ultrasound, fetal MRI and postnatal MRI. We can see we have a normal vermis with a normal primary fissure, normal 1 to 2 ratio, but it's upwards rotated, and we have a normal insertion of our tentorium, which we can see over here. If we're going to look at the Dandy-Walker malformation, what can we see then? Then we have again an open fourth ventricle in the axial plane. If we look sagittally, we have a partial or complete agenesis of the vermis. We have a superior rotation of the vermis, and we have a high insertion of the tentorium. And generally, Dandy-Walker malformations have a poor prognosis because they're associated to other malformations in the brain, like in the cerebrum, but also a high chance of genetic abnormalities. And as I said before, this is a problem of the anterior part of the membranous area, this part over here. And here we have an abnormal position of the choroid plexus. What does it look like? Again, in the axial plane, we can see an open fourth ventricle. And in the sagittal planes, we can see that we have a superior rotation of an abnormal firmus. And we hardly can see a fastigium over here. We're not really sure what's the primary fissure. And we do not have this ratio of 1 to 2 if we look at the tissue of the firmus. And besides that, we can see an elevated torcular. And the insertion of the torcular is high, where it actually should be somewhere over here. Or here, if we look at the neck muscles, it should be over here. The prognosis of the Dandy Walker malformation depends on if there are any malformations in the anatomy and the development of the cerebrum. Also, if there are associated malformations outside the central nervous system, if there are any genetic abnormalities. But what is also important is the size and the lobulation of the firmus. The more tissue has developed, the better the prognosis of the baby will be. If we look at these two babies, fetuses, we think that the development of this baby will be better than the development of this baby, because here is more tissue developed. What's also important, what you can see more often if you look at Dandy Walker malformations, is this tail sign over here. It's a structure which is on the outside of the firmus. In normal development, this should disappear during development, but if it stays there and you can see it constantly, then you know that the development has been abnormal. Then if we look at the vermin hypoplasia, this was previously often referred as a Dandy Walker variant or a Dandy Walker continuum. But in the older literature, all the posterior fossa malformations were called a Dandy Walker variant. And in this literature, you often saw that the prognosis of some of the variants was good or normal. But now we know that this must have been the megacisternal magnus and Blake's pouch cysts or persistent Blake's pouch, which have a good prognosis. The vermin hypoplasia is a collection of more rare posterior fossa malformations, also with an open fourth ventricle when you look in the axial plane. If you look at the sagittal plane, you have a hypoplastic firmus, often a small cerebellum, so a small TCD, a superior rotation of the firmus, but not always. And mostly you have a normal insertion of the tentorium, and there's a high risk of an abnormal neurodevelopment. And this is also a problem of the anterior part of the membranous area with an abnormal position of the choroid plexus. In the axial view, we can see this. And if we look sagittally, again, we have a superior rotation of an abnormal firmus. It's completely abnormal there, and mostly a normal torcular. Then how we can recognize the difference between these malformations. I've said it on the beginning. We look at the shape of the fourth ventricle, the upward rotation of the cerebellum, the insertion of the tentorium, the shape and the size of the firmus, and the position of the choroid plexus. First, the shape of the fourth ventricle. If we have a Blake's pouch cyst, this looks like an hourglass. But if we have a Dandy Walker malformation or vermin hypoplasia, this is more V-shaped. The shape of the fourth ventricle could also be a marker for severe fermion dysgenesis or agenesis in malformations with a closed fourth ventricle. And this is a study by Haratz et al. And she says in a normal fourth ventricle, the width of the fourth ventricle should be bigger than the height of the fourth ventricle. And so this ratio should be more than 1. And if this ratio is below 1, then something's wrong. And you can see over here some of the malformations. And so for instance here the Joubert ciliopathy, and where you can see that the height of the fourth ventricle is more than the width. And you also can see the hyperplasia of the cerebral peduncles. Here we have a case of rhomboencephalosynopsis where there is no vermis, but both cerebellar hemispheres are fused. This is a gallstone malformation, which is a migration disorder, and here you also can see that the fourth ventricle is abnormal. And this is a pontocerebellar hypoplasia with also an abnormal shape of the fourth ventricle. Second, we can look at the upward rotation of the cerebellum, and here our brainstem vermis angle can help us. You can also look at the angle between the brainstem and the tentorium, but there's a lot of overlap between the different groups. So the brainstem and vermis angle is easier to use. If this brainstem vermis angle is below the 18 degrees, you say it's a normal posterior fossa. If it's below 30, you have a Blake spout cyst, and if it's above 45 degrees, you have a Dandy Walker malformation. If you go back to this table again, you can see the Blake spout cyst, and the mean angle is 23 with a range between 19 and 26. And if it's a Dandy Walker malformation, the mean is 63 degrees and with a range of 45 to 112. And so if we look at these degrees, and then you have, and then this can help us to differentiate between the different malformations. Then if we look at the insertion of the tentorium, and when we have a Blake spout cyst, we have a normal insertion of the torcular. With the vermin hypoplasia, we mostly also have a normal insertion of the torcular. And when we have a Dandy Walker malformation, we have a high insertion of the torcular. Then the shape and the size of the vermis. And we said there should be a normal fastigium or a normal fourth ventricle and a normal ratio of 1 to 2 if we look at the tissue above and below the primary fissure. We can also measure the size of the vermis, and we can look at the distance from coronal to caudal, but also from anterior to posterior. And then we have tables in which we can find what should be the normal measurements. We could also look at the size of the vermis area in ratio with the biparietal diameter as a sign of the gestational age. And if this area divided by the BPD is more than 1.1, it's probably a persistent Blake pouch. And if this ratio is below the 1.1, it's probably a vermin hypoplasia or Dandy Walker malformation, which sounds logic, because if we have a persistent Blake pouch, then we know that the vermis is normal. It's only rotated upwards. And if we have a vermin hypoplasia or Dandy Walker, then we know that the vermis is too small. And last but not least, the position of the choroid plexus, which is situated normal inside the first ventricle, over here. And what we said before, it develops from this plicochoroidea over here. And then should be on the top of the Blake's pouch, a little bit below the vermis. This is a study by Palladini et al. And I have to admit, this is a challenge because we can only look at the position of the choroid plexus in 3D and when there's an upward rotation of the cerebellum. Here we can see the persistent Blake's pouch. We can see a 3D volume. This is the sagittal view, where we have the vermis, a normal vermis, which is rotated upwards. And if we look at the coronal view or the axial view, you can see here the pouch. And you can see that the choroid plexus is situated a little bit on top of the pouch and a little bit lateral, which is the normal position. So Blake's pouch, a problem of the posterior membranous area with a normal position of the plexus. If we look at the Dandy Walker and the vermine hypoplasia, we can see over here the Dandy Walker malformation. Again, this is the sagittal view, where we can see an abnormal vermis, which is rotated upwards. And if we look here at the coronal view, we can see the cyst over here. And you can see that the position of the choroid plexus is on the inferior part of the cyst. And this is a problem of the anterior membranous area with an abnormal position of the plexus. So I would like to conclude with these take-home messages. If there's an isolated megacisterna magna or Blake's pouch cyst, they represent the bulk of the posterior fossa malformations. If we see something in the posterior fossa, you have to look for associated anomalies and you have to do an advanced neurosonography scan. You have to assess the fetal brain and cerebellum in the axial, but also in the sagittal and coronal planes. Of course, MRI can help us to add to the diagnosis. And I also have to admit that there are posterior fossa anomalies that are really difficult or impossible to diagnose antenatally. Okay, thank you for your attention.